Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA Primary Exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out gasgasgas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hi everyone, this is James at GasGasGas. Today we are getting stuck into bupivacaine, thinking about friends that you might mix with bupivacaine. Going to touch on action potentials in cardiac and neuronal tissues, break down all the additives that you might want to introduce alongside your local anaesthetic agent, and then touch on levobupivacaine, why it's different, why we seem to like it. Since the last episode, I have managed to set up a donation system that's using PayPal. If you think you want to support the show, there's a link in the show notes for it. Any sort of donation is appreciated, or if you don't fancy that, just leave me a review. Tell me if you like it or not, because that'll keep me going. Because sometimes it does sound and feel like you're sort of shouting into the ether, although I know the stats for the podcast are always on the upward trend. It always helps to know if I can do anything better. Anyway, on to bupivacaine. So this is a local anaesthetic agent, but it's an amide local anaesthetic agent. We touched on it in the introduction episode. Remember, the other local anaesthetic agent is esters. So its colour, its appearance, how you might want to introduce it. So it's a clear, colourless solution, and it contains a racemic mixture of R and S enantiomers of bupivacaine. Classically, it is provided in concentrations of 0.25 and 0.5% solution, although there are 0.75% preparations as well. There are a number of preparations also combined with adrenaline in a 1 in 200,000 solution. Noting, guys, that this doesn't improve the length of block, but improves the surgical field for the surgeons, so there's less blood sloshing around. Bupivacaine is also supplied as a hyperbaric mixture, aka heavy bupivacaine, and this is mixed with 80 milligrams per mil of glucose, creating that higher specific gravity that means that we can manipulate how local anaesthetic works in people's CSF spaces. Cool. Its molecular weight, for those who are deeply excited by such a thing, is 288 grams per mol. So, pharmacodynamics of bupivacaine. So it works by sodium channel blockade. Let's remember that there's sodium channels in a number of places in the human. We're interested in the sodium channels you will find on neuronal membranes, at least initially. But first, let's think about the details of this mechanism. So we know that the pKa influences onset time because the unionized fraction is the one we're interested in when it comes to drug getting in the right place to work. We also know that its lipid solubility plays a role in this. And let's recall that protein binding plays a role in how prolonged the action of the local anaesthetic is. The more protein bound, generally the longer it lasts. But we need to bear in mind that this unionized fraction gets into the nerve, but then it's going to re-dissociate because everything is in a dynamic equilibrium, isn't it? And it's the ionized fraction of the re-dissociated molecule that's got into the nerve that is the one that actually does the sodium channel blockade. So you can imagine that for the amount of agent you give, the amount that actually makes it to the effect site is quite a small fraction. And we know that this plays out in most drugs we administer to humans. Go back and listen to any of those other episodes if you don't have a Scooby-Doo what I'm on about. Maybe start with the polycompartmental model episodes or the TCI propofol episode. So let's focus back in on local anaesthetics and this sodium channel they act on. So this sodium channel, you'll find it in your neuron, generally speaking, in those nodes of Ranvier, and it has 3 states. 2 natural human-y type states, i.e. open, it's letting sodium in, or closed, it's not letting sodium in. But then also a local anaesthetic bound state, because we know that if you have a protein and then you stick something to that protein, it causes a conformational change to that thing. That's why all these drugs have influences on all these proteins, G-protein coupled receptors, channels, tyrosine kinase receptors, etc., etc., etc. Something binds to something, changing the shape of the thing and altering its activity. Now, interestingly, local anaesthetic agents prefer the open state, i.e. that open state enables a higher affinity of local anaesthetic to sodium channel. This is called use-dependent or phasic block, if you want to apply a buzzword to it. So before I get back into the depths of bupivacaine, let's just quickly touch on these neuronal action potential phases, because we're going to do it properly in perhaps 3.5 decades when we finally get onto physiology. The curriculum is massive, but remember, this is something you might be asked to draw in the exam. So for a neuron, i.e. a nerve that is conducting something in your peripheral nervous system, there are 4 phases, and the graph is a graph of a line running at a sort of basal electronegative state with then a rapid upshoot and then a rapid downshoot. There's no middle ground, there's no plateau phase in a nerve action potential. So when your action potential comes along, some volt-gated sodium channels open, because naturally there has to be a degree of conduction at this point in time, doesn't there? However, once a sufficient number of volt-gated sodium channels open that you hit a shift in your neuronal electronegativity, deflecting back towards positive, i.e. when you hit about minus 55 millivolts, you trigger widespread volt-gated sodium channel opening. So loads of sodium pours into the cell. Remember that there's lots of sodium outside of a cell, not much in. There's loads of potassium inside a cell, and there's not much out. So all that sodium piles on in, and the neuronal membrane becomes positive. These sodium channels don't stay open forever. However, once you hit that positive state, volt-gated potassium channels trigger open, allowing efflux of potassium, triggering a repolarization of that nerve back into the world of electronegativity. Interestingly, nerves of the peripheral nervous system type flavour overshoot their electronegativity as they repolarize. So they dip down a little bit more negative than they otherwise would rest at before returning to that resting negative neuronal potential, waiting for a new action potential to flow along. 4 phases, 1, 2, 3, and 4. No plateau. So back to bupivacaine. What do we use bupivacaine for? So I'm sure you're all kind of thinking this is daft, but you might get asked it in the exam. So it is used for post-operative pain control when you've administered a block at the end of surgery, i.e. you've done a tap block, or the surgeons have done an ilioinguinal block for an inguinal hernia. You could utilize it for intraoperative pain control. So this is the realms of your spinal anaesthetic, or you're thinking you want to actually cover the operative intervention with some form of local anaesthesia, a spinal and a GA, for example. And then regional blockade, either to facilitate surgery, upper limb blocks, lower limb blocks, or regional blockade following traumatic injury. So I think we're ending up using erector spinae plane blocks and serratus anterior blocks and paravertebrals much more frequently to provide pain control. You could break this down further into anaesthesia that achieves sensory blockade or sensory and motor blockade, because we like to differentiate some limb blocks as motor sparing, which the orthopods love for their knee replacements. But that's more detail than we're going into today. So dosing. How do we dose bupivacaine? So it depends where you're putting it, doesn't it? Because you could, in theory, do 2 milligrams per kilo intrathecally. That isn't a toxic dose from the perspective of local anaesthetic toxicity, but you would have a total spinal and a very cardiovascularly unstable patient. Generally speaking, most people go up to 15 milligrams of intrathecal bupivacaine, i.e. 3 mils of 0.5. You can go quite low, and sometimes people go a touch higher. I do know, having had a nosy about this for bilateral hip or knee replacements, which they do in some sites in the United States, they put quite a bit more. They might go up to 7 mils of 0.5 intrathecally, because they're going to do both hips at once. Not something that tends to happen so much in the UK. So other routes, remember we have intrathecal, we have epidural, and in this site you can go up to 2 milligrams per kilo. You have infiltration, again 2 milligrams per kilo. That's injecting your caesarean section incision site at the end of a case, or rectus sheath catheters. Topical, I don't really know how much topical bupivacaine anyone's using. If people are, let me know. And intravenous dosing, we don't tend to do that. You can use other local anaesthetics in an intravenous manner, lidocaine and prilocaine in Beer's blocks, if I remember correctly. And I did, because I've just checked. And can you put it intra-arterially? No, it's going to be just as toxic. It's just going to take slightly longer to work. And what I mean mean by work is slightly longer to cause a local anaesthetic toxicity disaster. You might get a slightly mixed picture if you were to inject that into carotid, because you're going to get CNS symptoms very quickly and then cardiac symptoms a bit later, because it's got to go all through the brain and back down. So we've mentioned toxicity hard quite a few times here. The toxic dose of bupivacaine is 2 milligrams per kilo. Now, is that if you stick 2 milligrams per kilo into someone's vein, you will get away with it? And the answer is no, you won't. So 2 milligrams per kilo is your infiltrative safe dose. Bearing in mind, we all know that local anaesthetic uptake differs depending on the site you've injected it in. Mentioned that in the previous episode, you can go back and have a listen. But now we're thinking we've chucked this dose of bupivacaine in around someone's brachial plexus. How long does it take to work? I would generally quote to patients 10 to 20 minutes, but sometimes it can be even longer than that. Auxiliary blocks seem to take ages to cook. Now, if you've sold a regional anaesthetic to a patient with excellent skill, having balanced their risks and benefits and consented them appropriately, but then you forgot to tell them it takes a while, you've stuck that injection in, and then you've started pottering around and doing other things, and they're looking at you with raised eyebrows, you've lost your patient a little bit there. So open the door with how long it takes to work. But then, it does last for up to 16 hours, and sometimes a bit longer with additives. So you might have seen some folk mixing drugs together. Wouldn't it be dandy if we could use a local anaesthetic that acts really quickly and then mix it with one that takes longer to work but lasts longer, so that you get the best of both worlds, fast acting and lasts a while? Unfortunately, it doesn't quite 100% work like that. So say we take lidocaine and mix it with bupivacaine. Seems like a great idea. We've taken 1 ml of 2% lidocaine and we've mixed it with 1 ml of 0.5% bupivacaine. What this actually ends up giving you is a 2 milliliter mixture that is itself 1% lidocaine and 0.25% bupivacaine. And you're probably thinking right now, well, that's not the end of the world, is it? And technically no, but there's another complicating factor here, in that the pH of lidocaine in its natural form is different to that of bupivacaine. And herein lies an issue. Now, we're going to touch on bupivacaine pKa in a minute, but the pKa is 8.1 and it is 15% unionized, whereas lidocaine, 7.7. 25% unionized. However, the pH of lidocaine is more acidic than the pH of your good old-fashioned ampule of bupivacaine. So actually, you create a more acidic environment for the bupivacaine to work. And as we all know, bupivacaine wants to be more alkali. Therefore, you actually impair the function of your long-acting agent. So it fails on 2 counts of physicochemical reality, so you just don't do it. Now, there's a great paper that I'm going to link in the show notes that explores pharmacological and clinical implications of local anaesthetic mixtures, and it's a narrative review, and it's really good. So I would thoroughly recommend reading that. But you might have heard about mixing bicarb in with things. You've got that bum abscess, it's grotty, it's angry, it's inflamed, the tissues are acidic around it, the local anaesthetics just barely work. Wouldn't it be dandy if we could make it more alkaline with bicarb? And the answer is yes, you can. So if you mix in bicarb, you achieve a more alkaline environment and therefore improved onset time. Again, we hit another barrier here though, in that unfortunately bupivacaine, levobupivacaine and ropivacaine have a tendency to precipitate when mixed with bicarb, so that's kind of in the bin. However, lidocaine behaves, and therefore that is an option. Mix your lidocaine with bupivacaine. It's approximately 1 ml of 8.4% sodium bicarb per 10 ml of local anaesthetic. Some sites use a lidocaine bicarb mix for rapid onset of surgical anaesthesia via the epidural route in sections. You bang it in and it works real quick. So there are a number of other additives that are used, were used, could be used more in the future. Noting that you could mix clonidine in, that's compatible with lidocaine and bupivacaine. The evidence is mixed, but it may improve block duration. And again, dexmedetomidine, this is technically not compatible, but seemingly folks do use it, and that appears to extend block effect in some studies so far. Ketamine has been used, and it has a positive effect. Ketamine in itself has some local anaesthetic-like sodium channel blocking properties. However, there is some evidence that it is injurious to those nerves and the CNS. There's a degree of evidence that says that magnesium prolongs regional anaesthetic blockade. You just need to make sure you don't accidentally put a humongous amount intrathecally. Apparently that's happened. Steroids. There's mounting evidence that either co-administered steroids or IV high-dose steroids prolongs the effect of your local anaesthetic on nerve, although it may actually be that intravenous steroids work just as well with, a lower risk factor. You're putting less next to very important nerve structures, aren't you? Now, we know that opioids seem to improve the quality of neuraxial anaesthesia. I don't know about regional anaesthesia, and if you stick some fentanyl in someone's interscalene, whether or not that has any value. Obviously, these nerves have opiate receptors, but I wonder if anyone knows that, please drop me an email. So we've dipped quite deep into pharmacodynamics there before we've even got to side effects. These drugs do have a side effect profile, chiefly ones arising from toxicity, so we know they're toxic. Bupivacaine tends to favour the cardiovascular system, binding to myocardial proteins and blocking cardiac sodium channels. This impairs the phase 0 of the cardiac action potential, and we're going to touch on that in a second, but also can drop your peripheral vascular resistance or your systemic vascular resistance, as well as dropping your contractility and being arrhythmogenic. From a neuro perspective, we have sodium channels in our brains, unsurprisingly, everyone. You get a spectrum of effect here depending on how much agent has been absorbed and delivered to the brain. So these could come on very quickly if you've accidentally squirted some into a vein, and over a prolonged period of time if you've inadvertently overdosed someone in a highly vascular bit of tissue. So early signs, patients get some slightly excitatory effects. They get sensory disturbances like tinnitus, altered taste sensation, metal taste in mouth, circumoral tingling. They can then progress on to seizure activity and coma. Now, you could perhaps make an argument that if someone's in a coma due to local anaesthetics, then maybe they're going to not breathe very much. It's not really quite a side effect in some ways. And as I understand, there are no real quoted GI, renal, metabolic, or endocrine side effects of local anaesthetics that you're going to be asked about in the exam. It's all about the toxicity. And we touched on the action potentials of nerves. I just want to quickly differentiate the action potentials you see in myocardium, because this is something that interminably flummoxed me, because it all sounds exactly the same. And it's probably going to sound exactly the same to you, but consider it cognitive priming. So there are actually 5 phases of the cardiac action potential compared to a standard nerve with 4. You have a phase 0 and then a 1, 2, 3 and a 4. Now phase 0 is the initial depolarization, that uptick. You get sodium shifting in and potassium being able to shift out. There's phase 1, and this is a very small uptick at the top of this. If you imagine that initial depolarization phase almost overshoots slightly. Phase 1 happens, and there's a slight rebound repolarization, i.e. a drop in the positivity of that cell, only slightly, and this is due to briefly opened potassium channels letting some potassium in. Then you have phase 2, and this is the phase that you don't see in other neuronal action potentials, and it is the plateau phase. This is facilitated by calcium channels, and these are L-type calcium channels. I don't know if the L stands for long, but they open. They let calcium into the cell. This calcium was obviously quite useful for sarcoplasmic reticulum to contract, but calcium influx provides a prolonged period of positive cell membrane compared to good old-fashioned nerve. Phase 3, so this is our dip back towards electronegativity. Phase 3 is repolarization. Calcium channels that have been opened close. Potassium channels wide open here, allowing shift of potassium out of the cell, dropping it back towards electronegativity. And we get phase 4. This is the resting state, which is confusing really, because I would say that the resting state should be like first thing, but who knows? Anyway, phase 4, resting state, negative 96 millivolts. And this is facilitated by those potassium channels being open and a loss of whatever sodium and calcium channels remain trying to be opened. They're gone. So 5 phases, 0, 1, 2, 3, 4. 2 is the plateau phase. That's where you're getting all that calcium ingress courtesy of our L-type calcium channels. And let's remember that these L-type calcium channels are a drug target, folks. That's where your dihydropyridine and non-dihydropyridines come into play. Right, so quite a bit of talking thus far, but let's just touch on the pharmacokinetics of these drugs. Remember, pharmacokinetics is absorption, distribution, metabolism, and elimination. ADME. I mentioned earlier that the absorption behaviour, bupivacaine, depends on where it is injected and the vascularity of that site. So the range from most absorption to least absorption, we say intercostal, most, then caudal, then epidural, and then brachial plexus, and then subcutaneous administration. There is a linear dose-response relationship between peak plasma concentration you will see and the amount of drug you've put in. Vasoconstrictors in the world of bupivacaine do not influence this terribly much because bupivacaine has a local vasodilatory effect, which is bothersome. It's probably that the surgeons stick adrenaline in to make themselves feel better, and actually it probably doesn't change very much. This bears out in reality because we know it doesn't change how long the drug lasts for, because the bupivacaine causes dilation, which means there's clearance from that site. That same dilation is not altered by administering adrenaline. The time it lasts is the same, therefore who really knows? But if it makes them happy, doesn't matter, although you might see a little bit of that beta 1, beta 2 response that you get by administering adrenaline into subcutaneous tissues, and you might get a bit of hypotension and then hypertension. Very interesting. So, distribution. Its pKa, as mentioned above, is 8.1. So, at physiological pH, you have 15% unionized. It is 95% protein bound, which is mega, and in plasma, it is mostly bound to alpha-1 acid glycoprotein. It has a volume of distribution of 21 to 103 litres, but I don't really think it is terribly relevant for this drug. And it also binds to albumin. Metabolism. How does the body get rid of it? So bupivacaine undergoes N-dealkylation, remember that's a phase 2 metabolism liver thing, into pipecoloxylide. I don't think you need to know that, but it is inactive. So it gets through the liver, phase 2 metabolism, N-dealkylation, inactive metabolite. Clearance of 0.47 litres per minute, and the elimination half-life after intravenous administration is 0.3 to 0.6 hours, i.e. 20 to 40 minutes. So it does get out reasonably quickly. Other things of note. Remember that patients can be allergic to local anaesthetic agents, although classically more likely to be allergic to ester local anaesthetic agents than amide local anaesthetic agents. And interestingly, some vets administered up to 8 milligrams per kilo of bupivacaine when they were trying to do interscalene blocks on ducks, and none of the ducks died. However, we need to think that maybe it's quite hard to inject into the brachial plexus of a mallard duck, and maybe if they're squirting bupivacaine into a tendon or other fairly avascular structures, the odds are that it couldn't absorb quick enough to cause harm. Not that I'm recommending that as a dose, but I thought that was an interesting aside and reflects how easy it is to get very lost on the internet reading about things. So, just to close out the show, guys, and I hope you've managed to get here thus far, levobupivacaine, otherwise known as chirocaine, and chiro because it's all about chiral molecules and enantiomers, which we're going to touch on later. Levobupivacaine is the S enantiomer of the racemic bupivacaine mixture. Why are we interested in levobupivacaine? Well, it does seem to cause a bit less of a motor block, interestingly. It seems to yield sensory blocks more so, especially in lower doses. There is a notion that it is slightly less potent than its racemic mixture, which might make you think that if you were to take the other enantiomer, bupivacaine, you might have a more potent local anaesthetic agent. So why on earth did they bother trying to divvy this out and use one half of bupivacaine? And the answer is levobupivacaine is less cardiotoxic. If you were to pick which toxicity you would like, CNS toxicity, i.e. your brain turns off until you clear the local out, is probably less harmful than ventricular fibrillation. One, you just need to wait. The other one, you might not be able to undo. Hence why levobupivacaine is more readily favoured. What is the dose? So the max dose is generally quoted as 150 milligrams in one go, with a total of 400 milligrams over 24 hours. So this would work out at about 30 mils of 0.5% in an appropriately sized adult, or about 200 mils of 0.5% over 24 hours. In some literature, the max dose of levobupivacaine is quoted as 2.5 milligrams per kilo instead of the 2 milligrams per kilo of standard standard bupivacaine. This is why it tends to be favoured. It really confused me when I first started. Which one's levo, which one's bupivacaine, which one's chirocane, which one's marcaine? Chirocane is levobupivacaine. Standard bupivacaine is marcaine. Heavy marcaine is when it's mixed with glucose for intrathecal administration so it sinks down. And that's your lot, folks. You've listened to the end. You've done brilliantly well. That was bupivacaine with a touch on cardiac action potential, neuronal action potential, and additives you could mix in and their approximate likelihood of having clinical benefit. I think the jury is approximately out on most of it. There's no robust, consistent, everyone does one thing. I think I'd be tempted to say that steroids probably help and most other things might help, but it's less clear at this point in time. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.